Good. Okay, so we'll get started again. So this second half now is going to be on non-pigmented skin lesions. So moving on to that. Okay, so if we start with this one, I think we're going to start here with sort of the more concerning skin lesion and move on to easier, more simple, less worrying things as we go through. So who would be worried by this skin lesion if someone came and said, I've got this spot growing behind my ear and I thought you ought to have a look at it? Would this concern you?
I can't see the presentation now, Nikki.
Okay, you know, okay, let me just see. Can you see it now?
Yes.
Oh, let me know if it goes off again. Can you still see it?
Yeah, it disappeared momentarily, but it's back now. Okay,
good. Yeah, so somebody comes with this behind their ear that's been growing. What would your thoughts be about this? Would you think that looks concerning, something to worry about? Yeah. I saw you say yes, Sally, and your microphone's not on, but I could see you say that. Yeah, and I think, you know, absolutely that is something to be concerned about. Oh, has it just gone off again? Let me see why. Let me see if that works better. That's better. Can you see that now? Is that changed? Has that changed?
We can see that.
Yeah. Okay. I don't know why it didn't do that before. Yeah. And then when we think about this skin lesion and we look at it, this is what the description of this would be. So it's a nodule, which means it's a kind of lump, a raised skin lesion that you can kind of get hold of between your fingers. It's described as being pearly or shiny, and you can kind of see where it's shining in the light when you look at the surface of it. It has what's described as a rolled edge, so it's like you've taken the edge and just curled it inwards. So that's what is the rolled edge part of it. And then telangiectasia means that there's visible blood vessels within it. So I'm trying to get that pointer again, but oh, there we go. So you can see these blood vessels when you look at the skin lesion, and they branch a bit like trees. So if that was the trunk of a tree, then you can see all the branches coming off it. And those are the kind of features that we see in BCCs. So this is what's called a nodular BCC. So it's a nodule, and we did talk a little bit about BCCs before. I think you said, Rebecca, about BCCs, basal cell carcinomas, or rodent ulcers, and this is a very typical one. And this was the one. You can probably see some similarities now with a bit of a rolled edge, and it's a little bit shiny when you look at the surface there. You can't really see the telangiectasia in that one. And BCCs are the commonest type of skin cancer that we see. They account for 80% of all skin cancers. So these are what we're going to see lots of when we're looking at skin lesions, much more common than melanomas and things that we tend to think of when we think about skin cancers. And there are different types. The nodular type that we've just looked at, superficial BCCs, which I'll show you in a minute, which are also common. Then the more multifocal are much rarer things, and we're not going to particularly look at those. Nodular is the most common one, so the one that we've just looked at is what we're most commonly going to see. And risk factors for BCCs are they occur as people get older, so over time. So it's the elderly age group that we tend to see them in, although I have seen one in somebody who was late 30s. So that if you've had a lot of sun exposure, they can happen younger, but tend to be older people. They're sun related, so again, these are people who've had a lot of sun over time, maybe worked outdoors, lived abroad, things like that. They grow pretty slowly. They just keep growing, but at a slow rate, and they almost never metastasize. So although these are skin cancers, they don't get referred 2-week rule. They just go as an urgent referral because the risk of metastasizing is really quite low. And this isn't a great picture, but this is the best picture that I could find. And just to say, to be aware of superficial BCCs, and superficial BCCs look like pink scaly patches. If you look really closely, you can often see a little suggestion of a rolled edge around the side of them, but often they're just a kind of pink scaly patch. And I have tended to see these most often on people's backs. So if you see someone with kind of something on their back that's pink and scaly, just have this in the back of your mind. Often we end up trying a bit of topical steroid on it. If you have a pink scaly patch that doesn't respond to topical steroid at all, you should think about superficial BCCs and get them referred to be biopsied. And I have seen quite a few of these over the years where different people have used different creams, tried one thing, tried another thing, and nothing seems to change it. Just to have that suspicion in the back of your mind that it could be one of these superficial BCCs. And then moving on to something a little bit different. So this is someone's nose again. And if somebody came and said that they've kind of got this patch of skin that's dry on the side of their nose and gets a little bit scaly and the scales drop off, but it never goes away, would you be concerned about this one?
Yes, I would.
Yeah. And what would concern you? What would you be thinking if you saw that?
I know when I've seen similar things in the past, it's come back as like, is it actinic keratosis?
Yeah.
So not an urgent referral, but still needs some sort of dermatology input.
It needs some treatment. Yeah, and Sally Ann, you said you'd be worried about it as well because it's not healing and maybe some discharge. Yeah, both absolutely right. So you said you thought it was an actinic keratosis, which is absolutely right. So they're called actinic keratosis or sometimes solar keratosis. It's the same thing, and they're related to sun damage, and they're really quite common. I think NICE have said that in people over 60, about a quarter of people would have one or more of these. So if we went looking for them in our elderly population, we would find lots and lots of them. And the reason that we worry about these is because they're pre-malignant. So they're not skin cancers, but if we don't treat them, some of them will turn into some skin cancers, and obviously we don't know which ones are going to be the ones that change. So if we think something's an actinic keratosis, we should get some input, and you can treat them with creams or with cryotherapy, freezing them off, or sometimes surgery if they're very substantial. So where I worked before, I used to prescribe lots of creams for actinic keratosis. It was something I did basically every week, pretty much at work. I think in Lincoln, they don't like GPs to treat these, so I think they expect them to be referred on for specialist input. But the main thing is just to be aware that they're pre-malignant. And so often people will come with these saying they've got a patch of dry skin and they put moisturizer on and it doesn't get any better. And you can just and you can either see that it's quite rough like this, or often if you run your finger over that area, it feels a bit like sandpaper, and that can be the first sort of sign that they've got one. Okay, and actinic keratosis, they can look really quite different. So the one on the top right, it looks like quite a minor one. It's just a very small pink area with a little bit of scaling on it. The top left, it's got thicker scale on it, and then the one at the bottom, those are really quite thick, nasty looking skin lesions, and I'd be quite concerned about those, that they might be changing into SCCs. The things that make you think they could have changed would be kind of if they were becoming painful, if they'd started bleeding at all, if they're very, very thick. So I may have said this, it's only a low risk that they'll change into SCCs or squamous cell carcinomas, and different places say different things. I've seen figures of 0.1% changing up to about 10%, and it probably depends at what level you start looking at them, because the very minor SCCs maybe aren't, actinic keratosis maybe aren't included in that figure of the higher transformation. So sun exposure is really important. Commoner in men. I don't know whether that's because of sun exposure or just that men tend to form them more. And then we're thinking about people who are sensitive to the skin, so people with fair hair, fair skin. And this is a kind of common thing to see, a pink scaly patch on somebody's leg. Would that worry you at all? Not really.
Wouldn't particularly worry me. I'd probably try a mild steroid on it and see what happens, because there's no rolled out edges on it.
There is
more like just dry skin cells, maybe some eczema.
Yeah, good point. If we think about different things, what different things could it be? So you thought it could be a bit of dry skin or eczema. You mentioned about the rolled edge, so we're thinking the superficial BCC that we've just looked at would be another option. Any other options you could think of that this could be? No. So yeah, so have you heard of Bowen's disease? Yeah. And psoriasis would be the other thing that I was thinking of, and pink scaly patches on people's legs are quite interesting, and we've got to think about all of these things that they could be. Who was it that heard about Bowen's disease? What do you know about Bowen's disease?
I've heard of it. It can become malignant, can't it?
Yeah. Bowen's disease, again, is another important condition. It's not a skin cancer, but it can turn into skin cancer. And about 3%, so it's only a small percentage really, turn into skin cancers, but they tend to turn into quite aggressive skin cancers. So again, we want to treat this while it's pre-malignant before it turns into a skin cancer. It's another sun-related thing. So again, common in people with fair hair, fair skin, but this is more common in women, and it's really common on the lower legs of women. And I think probably because women wear skirts, I don't know why that particular area seems to develop them. You can get it anywhere, but it's a common thing on the lower legs. It grows slowly, and they're sort of, as we said, pink scaly patches. So I think exactly what you said, Rebecca, if you saw that, you might think, well, is it a bit of eczema or psoriasis or something? We could try some topical steroid. But if it's not any better with that, then again, just have it in the back of your mind about Bowen's disease and think, I need to refer this for it to be biopsied so that it can be treated. And I think we've looked at a few things now that are sun related. So people who've had a lot of sun could develop any of these skin cancers or precancerous things. And it's really important when you see somebody, say you saw this person and thought they might have Bowen's disease, just to have a thought of thinking, we need to look elsewhere as well, because this person might be coming with something on their leg, but they might have something suspicious elsewhere on their body. And I was reminded of this once when I saw a man who came with something on his leg, up on his thigh, and it really looked like it was a skin cancer. It looked like it was an SCC. So I was going to refer him, and I thought, I really need to just check the rest of your skin. So even though there's always time pressure, I kind of said, do you want me to have a look elsewhere? And he had what looked like a melanoma on his arm, very much like that first picture we looked at of the melanoma, kind of the most melanoma looking thing ever. So I was really glad that I had taken the time to do that. So just try and remember, if you can, to have a look elsewhere. So this is obviously a man's scalp. And if this person came and said, I've got this thing on my scalp, it bleeds a little bit, it scabs over, the scab drops off, and then there's another scab forms. I've had it for kind of months, slowly got a bit bigger. Would that sort of story and that picture worry you? Yes. So yes, we have one comment. Yes, and absolutely, I'm glad that would worry you? Any thoughts of what it is, or just I don't like the look of it, it must be something nasty?
I'd probably want to refer it. It's on an area where it's not got a lot of hair, so obviously high burn factor.
Yeah.
And the fact that it keeps scabbing over and not healing.
Yeah.
I'd be suspicious for a squamous cell.
Yeah. And you're absolutely right. And that's what it is, and that's one of the really worrying things, isn't it? People who come and say this thing keeps scabbing over, the scab drops off, it doesn't heal, it just scabs over again. That's a really suspicious story of something that's a squamous cell carcinoma. And what about these? So this is a similar kind of story, really. Things growing on the back of a man's hand. It's got a little scab in the centre, and they've just slowly grown, quite raised. You can see that the edges are quite raised from the skin, and these are both SCCs as well. So if that's what we see, a kind of thickening, raised skin, maybe get a scab, a little ulcer on the top, and it never heals. And SCCs, or squamous cell carcinomas, are the other important skin cancer that we're looking for. Second most common, so BCCs are the most common, SCCs are the next most common, and then we're down to melanoma, even though we think of melanoma when we think of skin cancer, but these are common and important as well. Tend to be more common in men, particularly as they get older. Sun radiation is a big risk factor, and also areas of chronic inflammation. So something that's been inflamed for a long time can turn into an SCC. And some of the things in the history that would suggest it might be an SCC, they can be painful, they can bleed, they can have sensory changes like itching, things like that. Usually they're in people who've got sudden damaged skin. And then they use this term indurated, and that means sort of that it feels firm. So when you press on these and touch them, they feel quite firm to the touch, and they do metastasize, and they all need a 2-week referral. And then these aren't very nice pictures, but just a reminder to always remove the scale. So if you see someone with a scaly patch on their scalp like this, if you take that scale off and it's all ulcerated underneath, that would be really suspicious that there's a cancer under there. So it would be easy to just think it's a buildup of scale, but if you can, remove it and just have a little peek underneath. So you can get quite scaly actinic keratoses, but if you take the scale off with those, you see just normal skin underneath. And the other thing to be aware of is if you've got leg ulcers that aren't healing, and you will all be a lot better at dealing with leg ulcers and knowing about those, but if they're not healing and not doing what you think they should be doing with the dressings that you're putting on, they can transform into squamous cell carcinomas, SCCs as well. So just be aware of that. If something's not healing, that it might just need a biopsy in case it is actually a cancer under there. So this is a sort of similar looking thing. Again, it's a nodule on the skin, and it's got a little scab in the centre. Would that worry you if someone showed you that on their skin? Yes. So Sally Ann, you'd be worried about that one as well. What would you be thinking it might be, or what is it that concerns you about it?
It's the scab in the centre. I know it's nice circular, but it's the scab in the centre. I'd be thinking of cancer with that one.
Yeah, and it looks a bit odd, doesn't it? This is in fact what's called a keratoacanthoma. You don't have to remember the name. And they're interesting actually, because when I first learned about these a long time ago now, what happens is they often develop after a scratch on the skin. So you might have cut your hand on something, and then this nodule starts growing, and they grow very, very rapidly. They can get up to a few centimetres in diameter. And then over the next 3 months or so, they just disappear. So we were taught about them as something that wasn't something to be concerned about, because they would sort themselves out in time. But now their whole guidance has changed, and they say you can't really distinguish between one of these and an SCC. So any of these should be referred as a possible SCC, squamous cell carcinoma. So exactly what you said. That's a really typical looking one. They're just that shape and they have a scab in the middle. And it goes a little bit back to that EFG rule, doesn't it? This is elevated, it would be firm to touch, it's growing, and that scabbed bit in the middle looks a bit concerning. So you're absolutely right, even though it is a keratoacanthoma, it should be just treated exactly the same as an SCC. So if I gave you a history with this one, this is obviously a man's ear. Oh, and if this person came and said, I've got this lump on my ear and it's really painful when I lie in bed and that's on that ear at night, and it's painful when I touch it, would you be worried about that?
Yeah, if it's got that scab in it and that scab's constantly there, I'll be more concerned.
Yeah, and what would you be concerned that it was?
Again, a cancer, the squamous cells, because with the scabbing on the top that's not healing.
Yeah,
that's a big flag.
so it's another one that when you look at it you think that looks a bit concerning.
Yeah.
It's actually, I don't know if you've heard of this, it's called chondrodermatitis nodularis helicis, which is a great name for something and sounds quite scary. And that's a benign thing actually, which isn't to say that you're wrong, Sally Ann. It's a condition that happens, and it happens because people lie on one side in bed all night, and so they get pressure on their ear at that point, and it develops a little nodule which becomes painful. But the differential diagnosis of it is a squamous cell carcinoma, an SCC. So you're absolutely right. If there's any doubts, particularly if it had been bleeding or the scab had kept coming off and it had kept not healing and just scabbing over again, then they are worth referring them. But if the history is typical and it's not ulcerated or scabbed and it's just a little nodule in the ear, then it may be just this chondrodermatitis, which is treated. If you can get the patient to sleep on the other side and not put pressure on it at night, it will get better. And that's really difficult to do because we all tend to sleep in the same way. And even if you try and sleep on the other side, you tend to turn over in the night. But you can get these pressure relieving cushions. So it's almost like they have a ring around it so that if you sleep on that side, you're sleeping on this cushion and not putting pressure on your ear. And they get better with that. Topical steroids can help them to resolve. Or if none of that works, then it's surgery. So I think so. If you saw something like this, if it's not too concerning looking, you can try and take the pressure off and use some topical steroid. But if it's not getting any better with that, then you do need to think about referring them. And as you say, if you're worried right from the start, I think this might be an SCC, then it's the right thing to do to just refer it and get it looked at and maybe biopsied. And would this one worry you if someone came with this that had grown on their face? Would you be I'd be worried if that was on my face just because I wouldn't like the look of it. But would you think that's something concerning if a patient came having grown one of these?
I think they're benign, aren't they? I've seen one of these before. I can't remember what it's called, but it's like a horny build up of the keratosis on the skin.
Yeah.
So they don't look nice, but I think they're usually benign. So
you wouldn't be too worried if you saw that?
I'd probably want one of my GPs to have a look at it and just check it with me.
Yeah, that's fair enough, really. So this is exactly what you said, really, a build-up of keratin to form a horn. So you can call it a keratin horn. But the important thing is not that it's just a build-up of keratin. What's important is what's happening at the bottom, what's caused it, why have you got one of these? And do you have any idea what sort of things can cause you to develop one of these growing on your skin? Do you know, Rebecca, from the ones that you've seen?
I think from the one that I saw previously, it was a basal cell, but I can't remember if that's the normal cause of them. This one was quite rolled out at the bottom edge, you could see, and then it had like a horny growth on the top. Right. I don't know about. Yes.
So it's the bottom that we look at. So it can be an actinic keratosis that's just gone a bit crazy and formed lots and lots of keratin and formed a horn. can be a seborrheic keratosis, those ones that we saw earlier, which were like the raisins squashed on the skin. Viral warts can do this, but then the important one is that it could be an SCC. So squamous cell carcinomas can form, we've seen them with little scabs in the centre. The keratin can just build up and form a horn. So I think you're probably right when you said they're likely to be benign. Probably more of them are benign than are malignant, but we just don't want to miss that squamous cell carcinoma. And there's a picture there. So we can see that's got a keratin horn, but if you look at the bottom of this, if you imagine the horn wasn't there, I think we'd probably all be quite worried about that. It would feel firm, it would be growing, and we'd be thinking actually that needs looking at. So maybe that was like the one that you'd seen, Rebecca, that had a sort of skin cancer at the bottom of it.
Yeah, I think it was, but I'm pretty sure it was a basal cell when they looked at the histology of it rather than a squamous cell.
Yeah. So, I mean, either way, getting it referred, definitely, if it looks like this at the bottom. So we need to just, if we see keratin horn, we don't kind of stop there with the diagnosis. We think, why have they got this? What's underlying it? And any concerns at all, it needs referring, doesn't it, to be taken off and get the histology of what's at the base. And then this one, would this concern you? If this was a sort of teenager and they had this, had grown quite quickly on their skin, and if you knock it, it bleeds a lot. It's not particularly growing now, but it had developed and grown fairly quickly to that sort of size, probably about 5 millimeters diameter. Would that concern you at all?
It looks a bit like a little hemangioma. It's not a very clear picture, but you want to see if it's, is it scaly, is it firm and things like that.
Yeah, and it does look like a hemangioma. It's quite vascular looking, isn't it?
Yeah.
And this is what we call a pyogenic granuloma, which is a kind of hemangioma. So it's a collection of blood vessels. And again, these often can develop after a bit of trauma. So you can scratch yourself with something and one of these can develop at that site. And they grow fairly quickly to this sort of size. And if you catch them on things or knock them, they will bleed a lot and can be quite dramatic. So what would you do with that? Would you think I need to refer it or leave it or any?
If it was, I'd probably want to refer to dermatology because if it's painful and bleeding and they keep knocking it, it might end up then getting infected and all sorts of issues. Yeah,
it's a nuisance, isn't it?
Yeah.
What we and I think I would feel the same. Like, you don't want to just leave someone with something like this that's unsightly and bleeding and causing problems. But what we're advised now, and these are fairly newer, actually I'm saying that, but that was in my diploma, which was 10 years ago, so it's not that new. They now think that it's really difficult to be sure whether this is a pyogenic granuloma or an amelanotic nodular melanoma, the ones that we talked about in the first session. So the advice now is to 2-week rule them all so that they can get the histology, because they're very, very similar to look at to an amelanotic melanoma. So, and we have to be a bit sensible with that, don't we? Because they're saying 2-week rule them all. If it's a young child, and you get these in children quite a lot, so if it was a 6-year-old that came and had this bleeding thing, they're not really going to get melanomas at that age. So I think in that situation, a referral to dermatology is appropriate because of it being a nuisance, but we wouldn't really be thinking of a skin cancer in that age. But someone who's a bit older and has one, they should go 2-week rule. These are the more straightforward things now. What do you think this is if someone had showed you this on their skin? It's a bit kind of chunkier than most of the ones that we see, but any thoughts about that?
Just looks like quite a big nevus, really, because it's all nice and.
It's a skin tag. So. Similar kind of thing. So you've probably all seen skin tags. We know that that they're just little growths we get on our skin, not particularly for any known reason. Again, they can come in areas of friction, so where clothing rubs or necklaces around the neck, we often see them, and they're harmless. I totally agree, Sally, and it does look like that raised nevus, that raised mole that we had earlier that was amelanotic, doesn't it? So, and if you thought it was a normal mole or a skin tag, it wouldn't really matter. It's harmless, isn't it? When you touch these, they're quite soft and squishy, and we've said about cancers kind of feeling firm, and it wouldn't feel like that at all. It'd be quite soft to touch. You've probably seen lots of these as well. What would you think if someone showed you this on their foot? I think you might have said then, Sally Ann, but you can't. Your microphone's off.
Verruca.
Yeah. So a viral wart, a verruca, and yeah. So a viral wart. And you've probably seen and treated lots of those, and we have them on fingers as well. So you've probably treated lots of them. The only thing that we have to be concerned about with viral warts, particularly ones on people's fingers, not on fingers, on people's faces or hands, is if somebody who's older has got just one single wart, because they're often multiple. If they've got just one wart, we have to think, could that be an SCC? So it's just to be aware, if you do see an older adult with just one wart somewhere, just have that in the back of your mind that it could be an SCC. Probably seen lots of these as well, common in children. What do you think those are?
Looks like molluscum.
Yeah,
Got a dimple in the middle.
That's right, absolutely, and that's the distinguishing thing, isn't it? So molluscum contagiosum, that's a viral infection of the skin. So we see it a lot in children, and you can see it in young adults as well. And they're little papules, so little growths that are usually reasonably small, and they have a little dimple in the middle, which is called an umbilicated. So it's called an umbilicated papule, and they're really the only things that look like that. So if you see those, they're harmless. Do you give them any treatment for these, or?
I don't, but they can last a long time. I know one of my children had it and she had it for nearly 2 years. It drove her absolutely insane.
Yeah,
it looks awful as well.
Yeah, I think you're absolutely right. They can last. 2 years is probably about the longest length of time they can last. So she was unfortunate, wasn't she? Generally last, in most cases, I would say up to about 18 months. So I think 2 years is quite a long time. They don't look particularly nice. They don't tend to cause any pain or itching, although sometimes the skin around them can go quite red. I don't know if that happened with your daughters. It did. Both my daughters had them. And if the skin around them goes quite red, we often end up giving some antibiotic cream or something because it all looks like it's got infected. But I think that's often a sort of inflammatory response in your body that means.
Yeah, I found that they got quite red and itchy and then just literally disappeared.
Yeah.
So it's like the inflammation flares up and then it's kind of like the body finally gets the grip of it and gets rid of it.
Yeah, that's exactly what happened with my children's as well. So I think that inflammation is when your body kicks in and fights them off. And we don't treat them. We used to, years ago, they used to kind of scrape at them with the wooden sticks. Again, I think because the trauma of that causes some inflammation and helps to fight it off. But it's painful and it's unpleasant, and we know these are harmless and they are going to go. So current guidance is to do nothing. There is a cream called Moludab. I think it's still on the market. There was a phase where parents used to come and kind of ask for that Moludab because it was licensed as a treatment to treat molluscum, but most CCGs didn't want you to prescribe anything because it was expensive and not necessary. So depending on what kind of practice where you work, you may get parents coming and asking for that. But general advice is to do nothing. Oh, I'll just I'll just stop sharing a minute because I just had a few more things that I wanted to put on before that. So let me just have a look and see why, because I think the other one that I was trying to share first was the right one to share. So just give me 1 second while I just have a look at this. Sorry, just give me 1 second while I just sort out this presentation. Okay, let me see if I can share the right screen. So I'll just see that. Can you see that on the screen now where it says, what is this common skin lesion? Yeah.
Yeah.
So what do you think of that if somebody came in and showed you that?
I'd probably want a closer look at it, but it looks like a comedone from first glance.
It does. Comedone is like a medical word for a blackhead. You're absolutely right. It does look a bit like a comedone. It isn't, but
it's got a lot of swelling surrounding it then, which would make me want to have the closer look at it.
And you can get giant comedones where you have a big kind of black head. I often see them on people's backs, and there's lots of kind of keratin and stuff within it. So it does look as if it could be one of those. What else could it be? I think this is a slightly confusing picture because it's black. What would you think if it wasn't black there? If it was just a sort of raised lump and it just had sort of a little hole looking thing there?
It's quite shiny, isn't it?
Yeah.
I'm not sure.
So this is actually a picture of what I know as sebaceous cysts, but they've renamed them. We're supposed to call them epidermoid cysts. I think because they're nothing to do with sebaceous glands. So the decision was they shouldn't really be called sebaceous cysts. And the typical thing that you see with those, so it would feel like a cyst if you felt it between your fingers. And they tend to have a little, what's called a punctum in them. So all sebaceous cysts have a little hole in them somewhere. And that's where, when they become infected, and they tend to burst, and that's where the stuff would come out of. So any cyst with a little hole in it would be what we call epidermoid cyst, and they don't tend to cause any problems. Lots of people have them. Scalps are common areas for them. They can be removed quite easily by surgery, and if they're getting infected recurrently, then it would be worth removing them. Otherwise, we don't really need to do that. Has the screen changed now? Am I on the right screen here? Does it say top tips, malignant versus benign? Yeah.
Yes, it does.
Yeah, thank you. Good. So when I was sort of putting all of this together about skin lesions, I got this. I am a member of the Primary Care Dermatology Society, and they send you like a magazine 2 or 3 times a year, and it just happened to come through the door about 3 or 4 weeks ago, and in there was an article about ways to decide with skin lesions whether they were malignant or benign, and they had 20 points in it. And I thought, well, that was quite good timing. And I thought I'd just borrow 10 of their points, which seemed relevant to what we were doing. So if we're trying to decide, because a lot of what we're trying to decide with skin lesions is whether it's something that's cancerous or malignant. So they'd put in the point that cancers feel firm. And I think that EFG rule that we talked about is really important there. So when you feel a cancer, it feels quite firm. They'd mentioned that some benign lesions will crumble off the skin, and that's particularly sort of seborrheic keratosis that we talked about, where bits drop off. Cancer, it doesn't happen with cancers. You don't tend to get bits that drop off. Be wary of any elevated things you see, because a lot of those could be cancers. Think of that EFG rule again, especially if they're fast growing. We talked about the ugly duckling sign, where you see something and it looks different to other things on that person's skin. So just remember that and think if it's something different, it's something to be suspicious of. Moles that have 2 or more colours in them are concerning. Things that don't heal, particularly if they're in areas of the skin that are exposed to the sun, be wary of those. That's a common story of squamous cell carcinomas. Family history is important, which we talked about right at the beginning. If people in your family have had melanomas, then you're more likely to develop them yourself. Think about the age of the patient. Most skin cancers happen as patients get older. Melanoma sort of being the exception, really, because it's common in younger people than other cancers. And I think, Rebecca, you mentioned right at the beginning about immunosuppressants, and they're important in terms of people developing cancers if they're on immunosuppressants. So these are the learning outcomes that we put at the start of the day. Do you think now that you would be happier to assess a person coming to see you about a skin lesion?
Yes, I do. Thank you. Yeah.
And have an idea of kind of what things suggest that skin lesions might be cancerous or malignant when you saw them.
Yeah.
Good. And presumably, I hope you could recognise some common skin lesions that we've looked at on those pictures. Do you think you would have an idea now of recognising some of those?
Yes, much better, thank you.
Yeah, good. So that's just the pictures again. So any questions about those non-pigmented things that we've talked about? It's a bit, there's a lot more different kinds of things in that section, but any questions about any of the ones that we've looked at today?
No.
No? Anybody? Okay. Thank you for listening, and thank you for joining in, and especially thank you, Sally Ann, for leaving your camera on, because it's really nice to look at someone's face, not just a computer screen. So thank you for that, and thank you for contributing. So I've just put together at the end a little quiz. I think there's about 8 pictures, and if everyone's happy just to join in and just see whether you've learned something this morning. So what I thought we could do is, do you know how to raise your hand?
No.
I kind of thought you might say that, Sally, and have a look at your screen.
Yeah.
And on that black bar at the top, there's a little picture of a sort of smiley face with its hand up. Can you see that?
I've got a hand, yeah, that's like
then
that.
if you click the hand, that means you put your hand up.
Oh, there we go. Oh, there we go.
Yeah.
Oh, yeah.
And then I think you click it again, you put your hand down. Okay, good.
Yeah.
So in the quiz, the main thing is going to be like, would this skin lesion concern you? And we'll put our hands up if we would be concerned. And then if anybody knows what it is, that's a bonus. This is the first picture. So if somebody showed you this, put your hand up if you'd be worried by this.
Yes, I do. I can't find my raised hand.
Okay. Well, good. I'm glad. Would you be worried by it, Deborah?
Yes, I think because it's irregular.
Yeah. Do you know how to raise your hand?
No, I can't find it. I'm trying to do this for you.
Okay, yeah, you've got your camera on. You can actually physically raise your hand. I didn't think about that. So the people that haven't got their hands raised, Christopher, I don't know are you still with us? You might have left. And I think Zoe has left. Good. So I think everyone who's here would be concerned, and I think that's absolutely right. What would you think this was? Why would it concern you?
I'd be referring for a suspected melanoma.
Yeah, absolutely. Good. You can put your hands down now. You just click the same thing and they'll disappear. Okay, brilliant. And what about this one? Would this concern you? This is a more tricky one, isn't it? So would you be thinking, oh, thanks, Gemma. Gemma said Zoe's with her. That's fine. So it's a joint effort there. So anybody concerned by this one? So Gemma, yeah. Anyone else? Deborah?
I'd want to touch it, I think, and feel it and all that.
Okay, and what would you be feeling for if you touched it?
I want to see if it's firm or if there's and look at it, see if I can see any, like if it looks a bit vascular as well.
Yeah, and Rebecca said that as well. She'd want to feel it. So yeah. The people who've got their hands up, what do you think it is, and sort of why are you concerned about this one?
I'd want to be touching it to see if it's like a button, I think, like a...
And Gemma said you'd be worried it might be a BCC. So I shouldn't have put this 1 second, but I think that is a hard one, and I think there's not enough information, is there, just looking at the picture? This could be like a sebaceous cyst that's got infected. So if it was painful and felt warm, and if you could see a little punctum in it, that would be one option. It could be one of those amelanotic melanomas or funny skin cancer things if it felt quite firm and was red. So I think probably that's fair enough from everybody, that we might be concerned or we might not be, and we want more information. So I think that is fine. But do you want to put your hands down now and we'll go for the next one? Okay, so we've got a ruler on this one. We know it's quite small. So put your hands up if this one would concern you, that it might be a skin cancer. Okay, no hands up, that's fine. I wouldn't be too worried either. What do you think this is?
Just a normal mole.
It is. I think it's a normal mole as well. I know when someone else looked at this slide, they thought, oh, it's a bit irregular. I'm a bit worried about it. I don't know, maybe this bit at the top or down the side here. And I think it is regular. And I think the problem is that in order to show a photograph at this size, you have to stretch something so much, and everything starts to look a bit irregular when you stretch it. And with the rules that we've got about deciding, really looking at it just with our naked eyes as it really is. So I think if you take a picture of something on your phone and then enlarge and enlarge it, it will always start to look irregular, and we need to just look at what it's like in real life. But yeah, normal mole. And here's one on somebody's cheek. So put your hand up if you think this might be a skin cancer. Okay, quick. Yeah, we've got lots and lots of hands up there. I think that's everybody. Good. And what kind of skin cancer do you think this is? Right, Rebecca says rodent ulcer.
I would have said that.
You think that as well? Everybody else think that as well? Anyone have any other thoughts? Yeah, perfect. So that is a rodent ulcer. It's got that rolled edge that we talked about. You can see the telangiectasia is quite shiny. So yeah, BCC or rodent ulcer. And those are the commonest skin cancers. So it's great that you just recognise that straight away. That was a really quick one for you all to put your hands up. So no question about it there. What about this one? This is something on someone's ear. Would you be worried about it, looking at it? Would you want more information? What information would you want?
I'd want to see the scaling.
Is it painful?
Is it painful? Yeah, good
It could
question.
be pressure damage.
Could be pressure damage, yeah.
Is it discharging? Sensation, what sensation it is like as well.
Yeah. And then I think one of the important things with this would be what's going on underneath that scale. If we can lift that scale off, what does it look like underneath? So, Rebecca, you were concerned by this one. What was it that concerned you? Oh, you've just written that as well, removing the scale to see under. That's really important. So, what were you thinking it might be, Rebecca?
I'd want to have a closer look because it looks a bit like a scaly actinic keratosis, and it's in the right part of the body for it.
Yeah. So absolutely, it could be an actinic keratosis with a lot of scale on it. If we took that scale off, if we managed to lift that off and it was ulcerated underneath, what would you think then?
Maybe a squamous cell. I'd want it referring.
Yeah. So if it was ulcerated under there, then we'd be thinking that looks like a squamous cell carcinoma, and ears are obviously quite vulnerable places because they're exposed to the sun a lot, and we tend to forget to put sun cream on our ears. Most people are quite good at putting it on the face, but you forget about the ears. But if the skin was quite normal under there, it may well be an actinic keratosis. So you're absolutely right. Okay, so if someone came and they said, oh, I've got this painful swelling on my skin, and you had a look at that, would you be thinking that looks like a cancer? Put your hand up if you think it might be a cancer, or keep your hand down if you're happy it's something benign. Okay, so no hands up, good. What do we think this is? Inflamed intradermal cyst. Yeah, and I think this is when we talked before about the sebaceous or epidermoid cysts. It looks like one of those, but it's quite red, and that's the punctum bit in the middle that we've seen. So yeah, I think it's likely to be an infected sebaceous cyst or infected epidermoid cyst. Good. Oh, and then this is more difficult to see actually, but this is a little thing on someone's lip. So put your hand up if that one worries you. Yep, you're worried by that one, Sally Ann. Anyone else? Yep. Yeah, so that's basically everybody, isn't it? And why would you be worried about this? What are you thinking with this one?
The cancer that you can get there, I can't remember the name of it. Someone presented the other day thinking that they had it. I can't think of its name. If you're immunosuppressed, you can get it.
Oh, I don't know what that specifically would be. I would be thinking about an SCC, a squamous cell carcinoma.
He gave you a name. He'd been on Google. And
that's interesting.
He Googled it, and I can't think what it was because I was like, pardon, I've never heard of that. And his wife had found it on the internet, and it looked like that.
Yeah. And yeah, Rebecca said a high risk area for sun damage. It is, isn't it? And I think lips are another place we don't particularly put sun cream on, or they get licked off, or when we eat and drink. So I think we would be very suspicious of things on people's lips. So yeah, I would be suspicious of an SCC. And you're making me wonder now what that thing is, Sally Ann, that the patients.
Yeah, he Googled it, and his wife had, because I'd never heard of it. When he went out, I Googled it myself.
Yeah.
And it tends to be in patients that are like immunosuppressed, and it is a form of a cancer. I can't think. I can't remember the name of it at all.
No, I'm trying to have a quick look myself, but nothing.
Yeah, he came with the name himself.
Oh well, that's something interesting for us all to have a chat. Okay. Oh, I didn't say hands down, but anyway, never mind. Take your hand down if anyone put your hand up if you're worried about this. So most people, everybody now, good. And what concerns you about this? What do you think this might be?
I think it might be a bit of a rodent ulcer underneath because of the rolled edge.
Yeah, there's definitely something going on at the bottom of this, isn't there? And you're right, they're more commonly squamous cell carcinomas that do this and form the keratin horn, but there's definitely some kind of growth at the base of it, so it definitely needs a 2-week referral. Rodent ulcers, basal cell carcinomas don't need 2-week referrals, they're just urgent referrals. But I think if you see a keratin horn with it, it's much more likely to be a squamous cell carcinoma, SCC, which are much more worrying and do need a 2-week rule. And Gemma said a firm base. Absolutely. I think when you felt that, you'd think this doesn't feel good. This feels like something cancerous going on. It just doesn't look very nice, does it? That was the end of my quiz, so well done. You pretty much said all the right things there, which is great. So yeah, so just to finish off, really, any questions about anything that we've talked about or anything that we haven't talked about that you hoped we would have talked about today? No questions?
No.
Okay, that's fine. So I'll send Ruth a handout for each of those, for the pigmented lesions and the non-pigmented lesions, which is basically my slides and my notes and things, and she can get those emailed over to you. So we'll do that when the meeting finishes. We'll do it now, and you can get those and just remind yourself of what we've talked about today. So I hope that makes things a little bit clearer for you, and you feel a bit more confident about dealing with skin lesions. And Rebecca's just put in the chat that she'd like a teaching session on common skin conditions. We did that, Rebecca. I can't remember when we did it now, Ruth, but we did it
back in November, a while ago.
Just a while ago. I think that's all recorded. So if you speak to Ruth, she can, how to have a look at that.
It is Rebecca's. The recording is on the Lincolnshire Training Hub website. So I can send you the link to that if you like.
I can stop sharing my screen because we're done. There we go.
In fact, I'll send out the slides from this presentation, from this session. I'll also send out a certificate to everyone who's attended and an evaluation form. And when I'm sending that out, I'll include the link to the previous webinar on common skin conditions. So anyone who hasn't watched that can watch that at their leisure.
Thank you.
Thank you.
Yeah, thank you. It's been nice nice working with you all this morning. So I hope that's useful. Okay. And Sally Ann, thank you very much for being my face that I looked at all morning. It's very much appreciated.
Okay.
Lovely. Well, thanks all for attending, and big thank you to Nikki for delivering the session today. And yeah, do keep an eye on our Facebook page, and we'll publish details of any upcoming courses on there, as well as via email.
Thank you very much.
Thank you.
Lovely. Thanks, Nikki.
Bye.